everybody, and I'm super keen that you're all involved. So let me just give you my quick assessment of what's happening. The overall epidemic curve for the world has really plateaued in the last 2 or 3 weeks. We'd been going on a super rapid acceleration through the last weeks of October and then into November. But then last week and a half of November and first week of December, the global number of COVID cases seems to have plateaued. Why is this? And the answer is that the European numbers have slowed, but they've not gone right down towards zero, which is quite a troubling thing. So the French Prime Minister went on television yesterday and said to the French people, and I paraphrase, he said, if we can get down to 5,000 new cases a day in France, then we can consider seriously relaxing life and having much more interplay between people in the run-up to Christmas. But the number of new cases of COVID reported in France yesterday was of the order of 10,000, i.e. twice the number that had been set as the threshold by the president for relaxing things. And so the news in the papers in France today is pretty depressing. It's basically saying that the threshold for releasing restrictions has not been reached. And that means that any prospect of free movement for French people during the period at the end of December is really not very high. It's very interesting that, and I think quite courageous. The UK figures, again, I've been looking at those, they're staying high too. They're more than 10,000 new cases a day. This is important. And do you remember, everybody, that one thing is to look at the numbers of new cases a day. The next thing is to look at the percentage of tests that are returning a positive result. If your percentage positivity level is up at 10% or more, that suggests that you've probably got a lot of undiagnosed COVID cases. So if you're running, for example, with 10,000 new cases a day, and your percent positivity is up at the 10% or so figure, then that is something that worries your prime minister or your president. She or he is going to say, this does not look good. Numbers are high and the percentage positivity rate is high. So we should be super careful about releasing our restrictions now, because the likelihood is that we'll just get a big surge in about 2 or 3 weeks' time. And so this is the dilemma facing European political leaders at the moment. On the one hand, they've got really frustrated populations, small businesses such as hospitality, like restaurants and hotels, going bankrupt, people really short of work and finding it hard to get temporary jobs. The usual temporary employment in this part of Europe this time of year is not easily available except in delivery firms. And altogether, an economically bleak situation, a socially difficult situation, and politicians are perceiving that their people want to be able to socialize, want the employment to return, but then these indicators are suggesting this virus is not going away in the way that had been hoped, and it makes it very tough. And I think that it will be difficult for France to relax restrictions a lot in the coming weeks. I think it will be really challenging in Britain. I think we will see further relaxation, but there will be still quite large parts of Britain that will be in a high level of restriction. And what do we say to our friends and our relatives? You know, do we want to prioritize seeing the family over the holiday period, which is really good for us all? We all want to see those we love. I want to see my children. I want to see my grandchildren very, very much. But do I prioritize that above my continued wish to be really respectful of this virus, my continued wish not accidentally to contribute to spread? I think it's very difficult. And we've been discussing this a lot in our team. Twee mentioned it in our last session on Tuesday, and last Friday, and made the point that it's proving to be quite difficult for her with her family. I hope she doesn't mind me repeating it. And I think this is the case for everyone, that they really do want to try to contribute to as little as possible surging of disease, yet at the same time, they've got some big pull from the family saying, come on, we've got to meet. So I'm hearing this all over, and I'm sure you all are as well. But my basic position is we've got to be super careful in the next few weeks. The chance of a very big further surge in Europe in January is high. And the impact on health services, the impact on the population could be very difficult. So I'm saying be careful, be careful. I've been through the United States information again. I went and looked at the Johns Hopkins meter showing numbers of cases, showing the distribution of the disease in the US. It continues to be very, very serious. I mentioned to you last time, the US is a surge country. And I'm reading of the really massive problems in Southern California. Catherine, my colleague who's sitting close to me, is from California herself. We don't like that situation in Southern California. It's not good. And it's a lot of poor people again. The people who are getting the COVID in the south of the state, they're not wealthy people. And it's suggesting there is really very intense transmission in part of the state. And the US death figures are high as well. So we don't like the look of the US. We don't like Mexico. We don't like Brazil. And we do see from several different parts of the world resurgence in places that had appeared to do really well with their first round of their battle with COVID, but they've got problems coming up again now. And there is resurgence in South Asia. There's resurgence in the Middle East. And so what does it lead us overall? Conclusion, the pandemic is still very much here. It is advancing, it's resurging, it's swirling, another word I'm using. And the only way to deal with this is to continue to be vigilant, to be alert, to be able to interrupt transmission, to trace contacts and to isolate the contacts, to isolate really well, and to protect those who are vulnerable. And we've got to go on doing this. And we've got to go on doing it, and we've got to go on doing it. We must not stop. And we have to do it well enough so that we can get the basic level of virus down. And if we do that, we can reopen economies. We've seen from countries in East Asia, we've seen from countries in other parts of the world that are doing so well, that it is possible to keep your economy open, provided you have really stringent rules about what you do if new cases emerge, but you can keep your economy open even with COVID as a constant threat. So I want to now go into the story about specific things that are happening around the world. And we wanted to talk about the first person who received the vaccine. I want to get Catherine to give us an update. Now, I was told of Margaret Keenan, who was the 90-year-old lady who got the vaccine, Catherine, was from Inniskillen. Is that correct? She got the vaccine, I know, in a local hospital in Coventry. But I listened to her, and Catherine, you're unmuted. Yeah. I think that she is herself from Inniskillen, which is not anywhere near Coventry. We could just find that out. But let's just do a bit of vaccine talk now, because I think this vaccine story is just quite remarkable, the speed with which vaccines have been developed. And also the development of vaccines using this experimental technology of establishing a vaccine that uses base pairs, in this case, the RNA from the virus. Is this a totally new technique? No. The team that were working on it, whether they were from Moderna in the US or from BioNTech, or it's pronounced BioNTech, BioNTech in Europe, these teams had been working on RNA vaccines for some time. They've been trying it out. And in fact, both groups had worked on a vaccine to the original SARS virus, the virus that Henk Bekkerdam worked on in 2003. And they actually had some success. They weren't 100% sure. So this is not as though it was a completely new technique just developed for this virus. They had actually built up a lot of expertise. They then started on this virus as soon as the base sequence for the virus came out in late January, early February. And they benefited from the fact that there was public reporting of the sequence of this virus very, very early on. So BioNTech is a small company with two Turkish microbiologists, and they of course linked up with the large company Pfizer. Their messenger RNA vaccine completed its phase 3 studies last month. Gosh, that was fast, you know, really, really quick that they went through from no vaccine to completing phase 3 in about 10 months. And then they did the necessary decoding of the information, showed that 95% efficacy. Now that was 95% basically protection against severe disease. What they've not been able to show is whether the vaccine actually stops the transmission of the virus. It's just shown protection against severe disease. And what they're looking at is protection against severe COVID disease 28 days after the first dose of vaccine. It's a two-dose vaccine. You need to have one shot, then a month later another shot. And the real pain about this vaccine, and there is only one pain, is you have to keep it at minus 70 degrees centigrade, or minus, is it 90 something, Catherine? Minus 70. Yeah, minus 10. In Fahrenheit it's minus 90 something. Yes, I mean, super, super cold. And to get stuff that cold, you have to use dry ice. You know what that stuff is. It's ice, but it kind of, when you kind of keep it at room temperature, it has lots of what looks like steam coming off it. We used to use it a lot in theatre. So it's a great vaccine, highly effective, seems to have incredibly low side effects at the moment. I mean, obviously you need to go on looking at it, but they say that vaccine side effects usually come really early. And looking at 40,000 people who've had it or who've had shots, and just looking at them 2 months after the shots, really very, very low side effects. And so there's a lot of promise with this vaccine. My sister, who's a general practitioner in Essex, near, I think, where Annie Feltham lives, tells me it's quite an issue to think through how they're going to administer this vaccine. And general practitioners, if they are going to be administering it, have quite major problems with getting it around. And what the general practitioners are doing in Britain is they're trying to get it to residential care homes so they can immunize people who are at great risk. Because that's what the British have done. They went for an emergency use authorization at the beginning of this week from the Medicines and Healthcare Regulatory Agency, MHRA. And that's an emergency authorization to use the vaccine to prevent illness and death among people at high risk. That's older people and people with other diseases. It's not been licensed in Britain for rollout to the general population. It's an emergency use authorization. But of course, they'll go back again and ask for the more detailed and wider authorization, which is what will happen in Europe eventually at the end of December as well. So there was a tiny little disagreement between the UK and Europe at the beginning of this week, but it was simply, as far as I can tell, the difference between an emergency use authorization for a defined subgroup of the population versus a provisional license for wider use. So this Pfizer and BioNTech vaccine has been given this emergency use authorization. The UK is only going to have 800,000 doses in the foreseeable future. That's enough to immunize 400,000 people. And they want to try to give it to health workers who are exposed a lot, as well as to the people at risk in the older age groups. They're not going to have enough to reach everybody. And then there's going to be an agonizing wait for more vaccine, because if we look at the overall capacity of BioNTech to produce vaccine, they can produce 1.3 billion doses in 2021. 1.3 billion doses covers about 650 million people. That's not very many. And we have to be very clear that we need more vaccines to be approved, really, if we're going to be able to seriously move beyond the use of this vaccine just to protect a small section of the population, to having a vaccine that can really get to everybody. And you know, it's not going to be good enough if the vaccine just goes to people who are fortunate and are well off from rich countries. You know, the real need is for this vaccine to go to poor people in poor countries who are at high risk. And that's where this special scheme, the COVAX scheme that WHO and the Global Alliance for Vaccines and Immunization and others are working on. And COVAX is a scheme that enables poor countries to be able to access vaccine that's made available through the manufacturers and provided at a reasonable cost. The difficulty is that there's not enough money in the COVAX scheme to make sure that it really can get to the poor people in poor countries. It's short by $5 billion. And so this is going to mean that in the coming weeks and months, there is going to be a real clamor from poor countries saying, what's going on here? We thought that the rich world was going to make certain that poor people could access vaccines, but now the vaccines are available, it's just going to the rich countries who are making a big fuss about it. But what about people in poor countries? And this is a big worry. So my advocacy relates to equity and ensuring that people in poor countries can get access. My advocacy relates to quickly getting a look at the other vaccines that are coming along. There's a messenger RNA or an mRNA vaccine coming from Moderna that's quite nice looking. It's had a good efficacy result. That's being looked at particularly by the US regulators right now. And because the US has bought quite a lot of doses of it in advance. And then there's a third vaccine that's been going through its phase 3 trials that's been developed by Oxford University and AstraZeneca, a more conventional vaccine. It's cheaper in cost. It can be kept at a warmer temperature at between 2 degrees and 8 degrees for a number of days. It seems to have a reasonably good efficacy. And so there's a lot of hope about that one. This will be particularly important for poor countries. But don't think it's just these 2 experimental vaccines and then the Oxford AstraZeneca vaccine. There's also a vaccine that's come from the Russian company, the Gamaleya National Center of Epidemiology and Microbiology in Moscow, that's supported by the Russian Direct Investment Fund. And they've got a vaccine that they're saying is 92% effective on, this is before it's gone into phase 3 trials, and it's now being administered in Moscow. It's having limited rollout from the Russian regulators, and it's basically a rather carefully constructed vaccine made up of adenovirus that's been also adapted to produce the coronavirus spike protein, and that means that it is effective. Now, it's important to know about this Sputnik 5 because this will be a vaccine that will not be so expensive. Lastly, there's a vaccine candidate that we know about that's come from China, from a company called Sinopharm. This is also being used in China, but it's being offered to other countries. And so both the Chinese and the Russian vaccine are likely to be made available elsewhere. Now, I want to say that life's going to get really complicated if you've got people who've been immunized with vaccines that have got different immunity profiles. This will actually impact the epidemiology of the virus. It will affect people who've been vaccinated in different ways. Some of them will not get the virus, quite a lot of them, but some of them will get the virus, but it will be attenuated. This is going to make life difficult. And I think everybody needs to be aware that it's not going to be a simple process of navigating coronavirus over the next 2 years with the continuing spread of the virus across the world, with people receiving varying amounts of different vaccines, and I've just told you about 5 of them, who will all have varying certificates. There may well end up being a certain amount of fake vaccine on offer. We know that fake vaccines are already being marketed, so it's going to be tough. And my colleagues in WHO are taking this very seriously. None of us think it's straightforward. There's going to be such a lot of demand for vaccines in different areas. And there's also going to be continued questions about the length of time for which you are immune. So our top line messages are vaccines are great, but please let us have very careful attention to who they're offered to, where they're offered, what records are kept after they've been offered. Secondly, the virus is still spreading. We are seeing extremely large numbers of cases. We've got more than 1.5 million people who've died of the disease, known to have died. We've got 66 million people reported as having it. And it is continuing to spread very rapidly. I don't even want to tell you how quickly we're getting 1 million new cases reported, but it is in a matter of days now. And so we must continue to work on this. And we've got a number of major problems still to work on if we're in Britain or if we're in developing countries, and it is not going away, and I don't want anybody to think it is. Now, one of the things that people have been looking at a lot is testing. Because of difficulties with testing, and because a lot of people appear to have asymptomatic COVID, a number of countries have said, well, why don't we just do mass testing of very large populations? And then when we find people are positive, then we ask them to isolate. And that might let us help us to actually get the overall number of people reduced in a population, because we're finding it so difficult to reduce numbers either through restrictions or through the more familiar means of doing case finding and contact tracing that we've been talking about so much in the past. Now, one of us, Henk Bekkerdam, has been doing work on mass testing, and I'm going to ask Henk to talk a little bit about what he's found. Then I'm going to go to other people to talk about any of the issues we want to. And Catherine is already offering me a number of points. We'll go into a little bit more detail about Margaret Keenan, the first person. Also, I thought we might listen to Lewis Thomas, who's going to talk to us about some of the clinical aspects. Lewis, how long can you stay? Can you stay long enough for us to have 5 minutes from Henk, or are you in such a hurry you need to come in and I need to stop Henk?
I can stay another 5 minutes, David. That's no problem.
Okay, fine. So Henk, would you like to just give us a brief observation? We've been exchanging quite a lot about this over the last couple of days. We spoke last night. Henk, over to you.
Thank you, David. And I would like to continue in that spirit about that. I think we are now at a stage where we have new tools and we have new opportunities. And I think especially on whatever I'm going to say, I think we shouldn't see it in light of that intensified testing that can be used in a combination with the vaccination strategy to faster and more responsible open up. And the main key is, and I think in some countries, and I think quite a few countries, the testing has been focusing very much about people with symptoms. At the same time, and the US CDC came recently with a quote on this one, they were making an assessment that they were thinking that actually 50% of the spreading of disease is actually coming from people without symptoms, either a pre-symptomatic or asymptomatic. So therefore, I think it's so important that you reach out to those who unknowingly start spreading the disease. And I think that's the whole concept also for the population test. But I would like to mention is I would still like to see the testing beyond the population test, which I think I will say one or two words about it. But I also still think already a little bit further along the line, if we're going to have tests which can quickly be done, these might also have opportunities to start responsibly opening up your businesses, to have events that people can attend to, which we're all longing forward to. So very quickly, and I think some of the things I think are you already have heard about. So the main thing is identify people without symptoms and who are carrying the virus, and to isolate those, but also, and I think what we have learned from especially from what's happening in Slovakia, not only isolate the person, but actually the whole household. And I think that's one important part we have learned already from Slovakia. The other part is that we do see that it could be a tool, either way to prevent lockdowns or to reduce the number of weeks to be in a lockdown. And I think that also comes back from, of course, if you want to go to population test or regional test, which I think has also now been considered by a few countries. Of course, it costs money, but let's please also think about how much does it cost to have a very strict lockdown. The other part which I was mentioning already is about how to open up for businesses, restaurants and bars, but also one other thing which is looks like a small one, but it all adds up. Also reducing the quarantine and isolation period for the contacts and the travelers. This is also very important because at the end, if you say, oh, travelers have to be for 10 days in quarantine, if you can have more tests, perhaps it can be only 5 days, etc. So I think these gains are all very important. Now go on the population test. I think Slovakia has been very positive. In the first round, the difference between the first and from the 0 round and the first round, they already saw a reduction of nearly 60%. When they were adding another round, it came down to 82. And what did they do? They had a few things which was very important why they were successful. One, it was in a very strict way done. If you didn't go for testing, then you had to be staying at home. And I don't think that many countries in the western part of Europe could do this, but at least it was a very strong participation push through the government. Then what happened is that they found quite a few patients who actually, people with this, not patients, people without symptoms, they were identified. And I think that was a major part of, if you take them out, they can also not do the spreading. And that's beyond from what most approaches has been. What is important is a rapid test, results within 1 hour. It's important that you do not require big lab capacities. It can be done right on the spot. And it can be done if you, especially in 2 episodes, you need to do it in a period of 5 or 7 days in between. But a high level population participation is of course important if you want to make a big impact. Now, some of you have most likely been reading about Liverpool, what happened over there. And I think something came out over there that they were actually missing 50% or catching 50%. I think this is important that you need to look at both. And 2 things came up. They used a different test and they did the self-test under supervision. It was not done by others. And we don't know what actually all these things have been able to contribute. Was the test not that good or was the self-testing was less good, etc. But even there, I think it has got some results even in the UK. So this is something I think we need to consider, which I'm very excited about if it would be successful, is the breed test. But there, I think that still needs to be looked into. There's some scientific things that are still going on. I would like to stop over here, but I only would like to mention only one thing, and David knows my line on this one. In the meantime, we need to start strengthening public health in each and every single country so that we can do the right things, that whatever people are remaining, that we can do the contact tracing, the isolation, etc. Thank you, David.
Thank you, marvelous. And I think we're going to hold this and go back to it. Lewis, did you want to come in quickly if you're still here? I'm sorry, I can't see you at the moment. Lewis Thomas.
Very quickly, David.
Thank you.
For those who haven't met before, I work in the NHS in the UK. I'm based in some hospitals in London, and we're receiving our first vaccines this week, as you may well have seen in the news. And I just wanted to share, I know there are so many complexities around it that have been discussed already on this call, and many more that people won't even have thought of yet. But it feels like such a positive step in our pandemic response, and to really being on the front line of this, the first positive intervention we've had. Obviously, we've had prevention interventions and coronavirus testing and masking and physical distancing, which have been vital. But there's a real sense of positivity and excitement about it. And I hope that it's something that can be rolled out on a larger scale and benefit people across the world, no matter where they live or what country they're from.
Lewis, that's lovely. So good. And I think you are expressing the sentiments that many on this call would like to express, that really getting the vaccines to the people who need them and not having them somehow stockpiled in rich places is the only way to go. Lewis, I do hope that you and your colleagues are looking after yourselves and are pacing yourselves. Those who are working in clinical medicine at the moment, I think, need all the support we can offer, particularly as they come to the end of the year. It's been a very, very trying year for people in clinical medicine. What are you going to do, Lewis, to manage the next few weeks and months yourself, or what are your colleagues doing to try to keep your morale up?
I think we're all working very hard, David, but I think it's about looking out for each other and making sure you tell each other to take a break when you're working very hard. And I think some of us have plans to take a few days off here and there over Christmas and the New Year. So it'll be nice to recharge then.
Thank you very much indeed. Good luck to you all. So here we are, we're on vaccines, we're on rapid tests and mass testing, we're on other aspects. Let's just give you a few bits of information. The lady who got her vaccination this morning as part of the UK rollout is called Margaret Keenan, and she received the vaccine from somebody called May Parsons. There was a bit of photo opportunity at the local hospital in Coventry. That Margaret Keenan herself comes from Enniskillen in Northern Ireland. Just to want you to have that. It is so interesting to be witnessing the enormity of the sense in some countries about this and what this means. Whether it's talking to journalists who are themselves super excited about it, or talking to others, members of the public, it is really important news. Thank you very much indeed. Does anybody else wants to talk about this immunization? I'm very keen. And Zenda says, Zenda, I'll read what you said, and if you want to say any more, you come in. Zenda says, David, in general, why is there no discussion of the Russian and Chinese vaccines? It's not only the West that can do things well or credibly, but it seems like that is where the narrative is going. Well, I can tell you absolutely, I wanted to talk about the Russian and Chinese vaccines today, and we went and did some research about them. The situation is that the manufacturers of vaccines have been telling their story through press releases, Zenda. It's not the normal way you do it. What you normally do is you get a file full of data that you offer to the regulator, and the regulator then decides whether or not your your magic compound is going to get an emergency use authorization or a provisional license or whatever. And it's normally a very confidential and private process, does not get done in the public eye. But for various reasons, a number of companies have decided to go public about their results. And that's led to the quite well publicized press releases. Obviously, there's been some public statements as well about Sputnik vaccine and also about the Sinopharm vaccine. But you are so right, Zenda. There's, if we look at where the world's vaccines are made and how they're looked after, an awful lot of vaccines are made in countries that do not have hugely expensive manufacturing. Their quality is second to none. They're very, very well quality controlled. And so I would agree with you totally. And that's why I am really keen to keep looking at Sputnik vaccine and the Sinopharm vaccine along with all the others. So good point from Zenda. Thank you very much indeed. The narrative, and Zenda has said at the end of her note, it seems like that is where the narrative is going, which is basically noting that there is a certain perhaps biased nature to some aspects of the narrative. Thank you, Zenda. Everybody get ready to come in. Anybody wants to talk about any of this would like to try to bring you in. Let's just go to Gawaha. Gawaha on Canada says that many provinces have hit the 2,000 cases a day mark. There are no Christmas gatherings in Montreal or Montreal. Gawaha, tell me a little bit more, please. And then I'll go to Tracy on British Columbia. It's quite interesting what's happening in Canada. It's not the same throughout the country. Go ahead, please.
No, it's not. Thank you, David. Always great to be here, and thank you to everybody online for their valuable inputs. Yes, Montreal has been quite critical. We're somewhat disappointed in the provincial government because they've been sort of seesawing. A few weeks ago, they declared a 4-day Christmas opportunity. Then a week later, they said, okay, it's going to be two days of gatherings of 10 people or more. They didn't present the science and the solutions. They just came out with declarations and then withdrew them, seeing that the numbers were spiking. And we've not had restaurants or sports facilities, and many activities have been stopped since October, and the numbers haven't gone down. Yeah. And then the final declaration a few days ago was to say no gatherings beyond your household. And that is quite concerning. I mean, if it has to be done, it has to be done. But it's just unfortunate that since September and the start of schools, and clearly the spikes happened in September, we haven't found a way to control it and give people a sense of normality. So it is.
Second wave down has been really difficult in Canada. And I mentioned it's been difficult in France and it's been difficult in UK. Catherine, I don't know whether you have any other data, but these, I mean, I've never liked referring to first wave and second wave, but this second round of infections has been harder to push down, I think, than people thought. Yes, they were able to get the numbers down at the beginning, but they've still stayed up quite high. So Montreal, no Christmas gatherings. So let's go to Tracy in British Columbia. I think, Tracy, you're in Vancouver, aren't you, or near Vancouver?
Yes, thank you, David. Right, yes, I am in Vancouver, and thank you for having me. So very similar to Montreal, although our numbers are not as high, it's spiking more rapidly here on a daily basis. Yeah. And so the new restrictions, some are official orders from public health, and our public health officer, Dr. Bonnie Henry, is just really, really good. She's on top of everything. But so she's trying to keep the economy going as well as possible. So essential services and essential commerce are allowed to continue, and she's trying to encourage people to do online shopping as opposed to going to the malls, which are decorated for Christmas.
Right.
So people have been flocking there, and I think that has been a big impact on the numbers that have gone up.
Yeah.
And we have a lot of protesters who, they're all fatigued, COVID fatigued, and they're going out, the anti-maskers are protesting and gathering. Unfortunately, we're getting mixed messages from the authorities who are trying to control that and stay on top of the orders. Sometimes these people are being fined and sometimes not. And the gatherings are being broken up and sometimes not. So that is very confusing for people, which compounds the problem. So Dr. Bonnie has been encouraging people to shop online, but people are still going out to the stores, and she's encouraging the Christmas retail businesses to put their product online and do curbside pickups and that sort of thing. So anyway, Christmas is off the table for social and family gatherings, and it's going to be virtual until January the 8th.
Wow.
So yeah, so that's, a lot of people are quite upset about that, but we're all planning our virtual celebrations and coming up with new ideas.
Tracy, I'm sorry about that, and do by all means let us know what the celebrations are going to involve. I'm particularly interested in finding out how people are developing an alternative way of celebrating Christmas and the New Year. It's going to be tough. I think this fact that numbers are holding up in a lot of different parts of the world, despite quite strenuous restrictions, is important. It suggests that just the level of transmission is just remaining stubbornly high. And a lot of this transmission is at household level. And that's why Henk Bekkerdam's point about the what you do if you're doing mass testing and you get positive results is very important. The whole house has to isolate. I'm going to come back to what Henk said in just a second. So to Gawaha and Tracy, thank you. I'm sorry the news is not good. I think we must go on as a community, this group here on this call, we must go on treating this virus with very great respect and not being scared, I think, of saying to our friends, our relatives, that we are going to treat it with respect, and we're going to play our part in trying to contribute to minimal spread. And I just want to stress that the businesses that are really in danger at the moment and that are likely to go bust in the next few weeks are really worried. And there's one industry in this part of the world that is in super difficulty, and that is winter sports. We are in the middle of it, somewhat being sucked into it. I'm sure it's the case also where you are, Tracy, in the Rockies. You've got winter sports there. There must be a lot of difficulty. What have you done about skiing in the Rockies in British Columbia, Tracy?
Thank you, David. Yes, I had meant to mention that sports have been restricted. We did have a group of hockey players who went to Alberta, and when they came back to BC, they brought COVID, and many people in the group were positive, and their families and people they were in contact with. So that spiked the numbers. So sports and restricted no contact sports whatsoever. The skiing industry is really suffering.
Yeah.
It's being well monitored. So fewer people are allowed on the mountain. There's a maximum that are allowed on the mountains. So they are suffering, but they are allowing skiers to go up at this point, but they have to ski in their own group. They can't go into the, I'm not sure about the warming huts. So yeah, I'll have to look into that.
Well, thank you very much indeed. I just want to stress that we've been saying you can get on top of this virus without having to go into lockdown. That's been the core hypothesis that the team and myself have been working on. John has been at the center of this. And so to Georgina, yeah, I mean, the fact is that countries all over the world have spent a huge amount of money in trying to keep businesses afloat, trying to provide social protection for people because of the economic situation. My friends in Thailand say they cannot afford any more. They are just broke. My friends in European countries are saying they're going to find it very, very difficult. I think we must not assume that more lockdowns are going to be affordable. They are going to be very, very difficult. And so the situation early next year is it really should be focusing minds. You can't afford lockdowns. You've got to get ahead of this virus. You've got to find ways of dealing with it. And that means you've got to invest in public health. Henk Bekkerdam's point, never was there a more urgent need for the investment in the basics of public health infrastructure than right now. John, if you want to come in or anybody else wants to come in, just wave your hands. I've got my lookout. What I'd now like to go to is Terry Jackson. In my previous experience in tackling pandemics, it's a factual question. What collaborative role has the Commonwealth played across the piece and what were the outcomes? I just want to say that we had brilliant Commonwealth collaboration on Ebola in West Africa. And there was an incredible willingness of Commonwealth countries to work together. That wasn't the only collaboration. We had brilliant African Union collaboration. The best teams that came in to help deal with the Ebola in West Africa came from the Democratic Republic of Congo and from Uganda. They were from the world expert centers in Ebola management. And we loved them and they were really appreciated. No patronizing guff here. They knew their stuff. And then the team that came from South Africa set up the most amazing instant lab in Sierra Leone. I remember working with them and being super impressed by the team that came. There was a combination of Commonwealth and African Union solidarity. We had companies coming in like ArcelorMittal, who were absolutely brilliant. And then we had really significant support from countries. So the US provided the best possible backup to Liberia, which is sometimes referred to as the 51st state. We had France providing amazing support to Guinea. I remember the negotiations with the president and with the relevant ministers in France led to a superb contingent that came from Paris and set up and did wonderful stuff with the Guineans. And then the UK, with a Royal Marines contingent, came and provided support to Sierra Leone, together with a number of UK civilian people. This level of cooperation from countries and from the African Union particularly, and from the Commonwealth and from the private sector was just brilliant. And that what the president of Liberia told me was when President Obama rang her up and said, we're coming to help, she said it just made my day, made my week, made my month, made my year. I wanted to go out and shout to my fellow citizens. It was wonderful to feel that we were not the forgotten country of Liberia that everybody was turning their back on. We were really valued by the president of the USA. Just one phone call transformed the way in which Liberia was dealing with Ebola. I keep trying to say that to people who want to cut foreign aid and who want to stop international cooperation. You were not sitting with President Sirleaf Johnson before the Obama call and after the Obama call and just seen the difference and then seen the difference in the country. These things really, really matter. And I will keep saying it. King Beckerdam, please. Question from Annie McLeod. She says, how good are tests at screening individuals really? Populations, yes, but how many households might go into lockdown based on a false positive, or on the opposite, spread the virus in a care home because of a false negative? Now, I've got my answer to that, but Henk, you've been studying these lateral flow antigen tests, and you've also looked at the story from Eastern Europe. You've also been looking at livable stuff. Could you answer Annie's question, please, Henk?
Now, David, I think you're well better read than myself, but I think these antigen tests, I think they're pretty good in detecting when you have a high viral load. They're missing some at the later bit, which I think is not so important. Generally, the infectiousness is also not so well related. It's one of the comments on the PCR test that they find still some remnants of the RNA and therefore they're positive. But where they are less sensitive is in this early part of the infection when it's starting and that you don't see yet a lot. So at the same time, the false negatives, and that might also be, and I have to admit, I should go far much more in detail. It was interesting what in Liverpool was used as a test and the one that was used in Slovakia.
Yeah.
And I think that the Slovakian one had a higher sensitivity and specificity. But I think, David, please come in over here.
Okay. Yeah, I mean, there's two things about these tests. One is how good is the sampling, and two is how reliable is the test. So in Slovakia, the testing was done by qualified people. And I don't know whether any of you have had the swab up your nose. It's super horrible. Catherine, tell me, what's it like? You had it done.
It is truly dreadful.
She says it is truly dreadful. You really get it scrunched up, right up to the top of your nose, and you get it right deep down in your throat, so you want to gag. That was the Slovakia. That was the real pros that did it, whereas Liverpool, I think it was self-administered, Henk.
Yeah, it was self-testing.
Vicky, was it self-administered or not in Liverpool
Yes.
when you had the mass testing? She said she's
Yes.
given a thumbs up. I was right. Vicky, I'm not going to ask you to talk about your experience at what it was like doing it yourself. You may not want to talk about it, but it makes a huge difference, especially if your viral load is small, is whether or not you're properly swabbed. Secondly, yes, there is a false negative thing, that i.e. you might have the virus and it might come out saying you haven't. And that's what you worry about. It's the false negatives that are the really serious ones. And my colleagues are saying, well, what you do is you repeat the test again and again and again. Fine, fine. If you've got the capacity to repeat the test, then you probably reduce your likelihood of a false negative. But this is a point of concern, Henk. One, the quality of swabbing. Two, whether the tests are reliable. And I think they're getting better. And I think the Slovakia test is thought by WHO to be pretty reliable. So let's keep watching. And those of you who want to get a copy of a really good analysis of the Slovakia test, I don't know whether I can find it, but I sent it to one of our groups. It was an article in the UK Guardian of a couple of days ago. I sent it to Henk.
I shared it online, David. I just shared it online.
You shared it.
I got it from you. Thanks.
It's a well-written piece, and I think it's reasonably right. I found it useful. I'm not going to say that there's not other features of it that we need to know about, but this I think that the quality of the swabbing matters a lot. Thank you, Henk. And thank you very much for...
And David, may I just add one thing? You were already mentioning it. What is important, I think, in a pandemic is not that you get the super test. I think action is more important. If you can get people out of the circulation or spreading it, that is key. And you need to communicate that, because that's the only thing what is important. That it's not all.
Let's just get the words out very clearly. You are out of circulation right the moment you are suspected of having the virus. You don't hang around. If you've got uncertainty, you isolate. And you isolate properly from the very beginning, and you obey it. Henk, you worked a lot on this. You told me that initially in Delhi, you were super worried. Initially in Delhi, you were pleased because there was some kind of officially managed isolation process. And you were nervous that in Bombay, that was not being done. And you were worried that people were not isolating so well because they were being told to stay at home, but the supervision was less good. You are you're really concerned about the quality of isolation, right? Henk?
Absolutely. And it was also linked to that we had quite a lot of infections in the slums where self-isolation is not realistic. And I think some countries have now also seen this, that sometimes when they know it, they make accommodation available that people can. But of course, that's only when the numbers are overwhelming, and because that is remains an issue.
So isolation means isolation. John, you've been looking, you said it last time, but I want you to just have a chance to say it again because it's so important. How's the isolation going in these UK cities where you're seeing quite a lot of spiking and surging? Is the isolation proving to be satisfactory from the perspective of the public health people?
Not really, no, David. I mean, there are various numbers quoted as to the percentage of people who are isolating properly. Somewhere between 18 to 25% is what's been quoted to me, and that's obviously low. You'd have to understand what people meant by properly and what the impact of, isolating for 6 days as opposed to 10, or going out to the shops to get your food and not. So what's included in that? But what we're finding is that the test and trace process is not getting to the people who really are at some of the epicenters. And they're people who need the money right now to work. And so unless we can wrap around them the sort of support that they need, that means that they can isolate, it's people who will not get back into work if they don't show up because they're on fixed term or 0-hour contracts. It's people who are taxi driving, and that's their source of income. So unless we can get to people who we need to get to more quickly and help them to isolate properly and understand what that means and make sure they've got the means around them to do that, then we're not going to get the isolation numbers that we want. And the purpose of the testing, testing is not a therapeutic, as somebody said. Testing is to help us get people doing the right things.
And we've always said that lockdown is not the solution. The solution is to interrupt transmission, and you can only interrupt transmission with really good isolation. Our colleagues in Australia told us this very, very clearly, and they really took the isolation seriously. And they found that when they didn't take their isolation seriously, they got cases building up again. John, in his research, is really concerned that the isolation is not complete. And this is possibly one of the reasons why things are just not working right. And we got a thing from Max Dunford making it very clear just now that there's something not right about this lockdown. I would add to that, it's because if you don't isolate properly, you don't interrupt transmission. Let's make a little jump now. Let's think about vaccines and developing countries. Joe Nichols, you've been studying the COVAX program. And you've seen some of what's involved. Would you like to give us just a very quick statement of what your concerns are about this effort that we are seeing put in place now to get the vaccines to developing countries?
Yeah, sure. So we've been discussing it from the perspective of Somalia, and the expectation is that Somalia should get support for getting 20% of the population vaccinated. So one big question is whether it makes a big difference to get just 20% of the population vaccinated, because probably the country won't have resources to vaccinate the remaining 80% of the population. Yeah. The other thing that has come up, and even come up from donors who are very willing to fund the effort, is that the amount of money that it will require to vaccinate just 20% is about a quarter of the amount that's spent on health services in a year. So, we have a lot of other problems in Somalia, from malaria to other infectious diseases. And they're asking, how can we make the most of this investment? Should we make it something that happens in parallel with childhood vaccinations? Can we roll it out using existing logistical methods? And then that brings in all of the challenges of, so if you do use existing logistical methods, do you use the military? And does that make it very difficult for some bits of the country to have that vaccination? So, I mean, it's just proving incredibly complicated to figure out what the rollout plan will look like.
These are super tough issues, Joe. I mean, just thinking back to the UN rules about who can use humanitarian flights, they're super negative about military on humanitarian flights, even if those military are involved in peacekeeping or peace maintenance. So involving the military is a problem. Also in Somalia, having soldiers roaming around the place will not always lead to joy among the populace, I suppose. So these are big, big questions. And there's no Father Christmas around the place saying, well, here's 20 million, just go and use it for what you need. This money is hard to get. And as you say, money going on COVID immunization is money not going for care for women or child health or malaria or whatever. What are the conversations like, Joe? Do you feel that everybody is pulling together? Is there still a willingness to try of the group to hold together, lean forward and find solutions? Or is there people walking away saying this is too difficult?
No, I think everybody is very keen to do the thing that is going to be best for public health. And I think the questions that people are asking is whether this is the best way to spend very limited amount of money on public health. And if it is, very, very much consensus that this is something we should push for, but at the same time recognizing, the polio vaccination is under rolled out, and the many childhood vaccinations are not reaching as many people as we want. So adult vaccination as a whole concept is brand new. It's going to be treated with suspicion, and certainly, as you say, involving anybody out of the ordinary is going to also cause suspicion. But there's definite willingness to make it work and enthusiasm around it.
So that's the best thing. There is willingness to make it work. There's enthusiasm. I talked to John and Kingasong, the head of the African Centers for Disease Control. I know they're struggling with so many tricky issues right across the continent. And this virus has not started in Africa. It's come from outside and it's been amplified in some of the richer nations of the world. But I continue to be amazingly impressed by the sang-froid, just the positive approach of the teams in different countries and in these different regional organizations who are already struggling and who are asked to add this to their list. So is the world coming behind the poor nations and poor communities? Are we seeing a real upbeat in the extent to which things are being done across the world? Well, there was a United Nations General Assembly special session last week. I'm just going to ask Catherine, we're reaching the end. I lost track of the time, as always. Catherine, did you feel that the UN General Assembly special session last week came out with some useful stuff? Do you feel that there's a real chance of money? I'm passing the microphone to you. What do you think? What did you think happened at all this stuff? Did you listen to some of the speeches?
I did. So I thought the actual content was really quite good. And I thought that the design was good. I am disappointed in two things. One, that there isn't a more concrete outcome.
Yeah.
I think it would have been more useful for us to have a sort of more concrete path. But then the other thing is, I don't know if everybody else noticed this, but the International Epidemic Preparedness Day that was declared was the 27th of December. And I find it hard to imagine how we're going to get a great deal of advocacy going between the 25th of December and the 1st of January for this. But otherwise, I thought the meeting itself was the content I thought was absolutely great.
So everybody, we are continuing, as you heard from Twee, to plan for the future of these open online briefings. Our view is that they are an absolute joy for us to be involved in. I love it. It's just so good that we have a community that's prepared to take a few risks, to talk with each other, to share, and it's done openly. We look at issues with an open mind and an open heart. We support each other emotionally, and we send tips to each other, and we will try to find the right formulation for keeping going, despite the fact that many of us are very, very busy. Just to conclude, I want to stress that this pandemic is continuing to be a really massive issue for the world, a massive issue for people everywhere, and it's not going to suddenly go away quietly. And just because we've got some vaccines, it doesn't mean that the virus is going to run away and disappear. It will actually be quite a problem for the coming months and I fear years. Meanwhile, myself and others are going to continue working on development issues, not just on health, but we're also going to work a lot on food and nutrition, because we think these issues are all connected. Twee, would you like to tell us a little bit about anything that you picked up today? I don't know whether you've got anything you want to bring in now, and then I will go to the closing sequence.
Thank you. I didn't run the poll today, but do want to say that I've shared the link to our survey. So we want to hear from you so we can build what may be a series 3 next year with your input. And then to say Friday morning, we're back here again. And then next week on Tuesday and Friday are our last 2 sessions. Please do join us. We, despite it being a pandemic and this being a difficult time for many, it is important to show how connected we are. So I am planning some surprises next week. So join us then.
And when Twee plans a surprise, it's pretty good fun, says David, who's been participating in one of our surprises. Everybody in this webinar is welcome. Everybody is valued. We value you, you value each other, you value us. We need these forms of fellowship more than ever, especially when we're working together on something that's so important.